Cardiology and Cardiothoracic Surgery Rapid Clinical Review. Question 1. Which of the following is the most common indication for adult cardiac transplantation worldwide? Options: A. Ischemic cardiomyopathy, B. Hypertrophic obstructive cardiomyopathy, C. Restrictive cardiomyopathy, D. Valvular cardiomyopathy. Answer A. Ischemic cardiomyopathy. This is essentially end-stage heart failure secondary to coronary artery disease and prior myocardial infarctions. It accounts for about 45% of cases. The example here is that ischemic and idiopathic dilated cardiomyopathy are the leading culprits. Question 2. In a patient undergoing CABG, which conduit has demonstrated the highest long-term patency rate, approaching 90% at 10 to 15 years postoperatively? Options: A. Great saphenous vein, B. Left internal mammary artery, or LIMA, C. Radial artery, D. Lesser saphenous vein. Answer B. The left internal mammary artery, or LIMA, to the LAD is the gold standard conduit. The reason is that it's a living, elastic artery that adapts and naturally resists atherosclerosis. Contrast this with the example regarding saphenous vein grafts, which suffer significant attrition and degradation over a decade. Question 3. 72-year-old male with exertional syncope, angina, dyspnea. Harsh crescendo-decrescendo systolic murmur at right upper sternal border, radiating to carotids, delayed carotid upstroke, also known as pulsus parvus et tardus. Options: A. Mitral stenosis, B. Aortic stenosis, C. Tricuspid regurgitation, D. Mitral regurgitation. Answer B. Aortic stenosis. The classic triad of advanced calcific aortic stenosis is angina, syncope, and dyspnea. The mechanical restriction of this tight, calcified valve produces the harsh murmur, and the example to lock in is that this restriction causes the delayed carotid upstroke, pulsus parvus et tardus. Question 4. What is the critical valve area threshold below which aortic stenosis is classified as severe, classically serving as an indication for intervention when symptoms are present? Options: A. Less than 2.0 square centimeters, B. Less than 1.5 square centimeters, C. Less than 1 square centimeter, D. Less than 0.5 square centimeters. Answer C. Less than 1.0 square centimeter. A valve area less than 1.0 square centimeter, or a mean pressure gradient greater than 40 millimeters of mercury, defines severe aortic stenosis. To put that into perspective, a normal valve area is roughly 3.0 to 4.0 square centimeters. Question 5. 45-year-old female, untreated childhood rheumatic fever, progressive fatigue, orthopnea, systemic thromboembolism. Loud S1, sharp opening snap, low-pitched rumbling diastolic murmur at apex. Options: A. Acute aortic insufficiency, B. Mitral stenosis, C. Tricuspid stenosis, D. Pulmonic regurgitation. Answer B. Mitral stenosis. Rheumatic fever is the overwhelming cause here. The fusion of the commissures creates a restrictive funnel that physically blocks left ventricular filling. The high-yield example is that the resulting left atrial dilation frequently triggers atrial fibrillation, creating a perfect setup for systemic embolic events and thrombosis. Question 6. Which valvular lesion is classically characterized by a high-pitched, blowing hollow systolic murmur heard best at the apex that radiates directly into the left axilla? Options: A. Mitral regurgitation, B. Mitral stenosis, C. Aortic regurgitation, D. Aortic stenosis. Answer A. Mitral regurgitation. This is abnormal backward flow from the high-pressure left ventricle into the lower-pressure left atrium throughout the entirety of systole. The key example to remember is the radiation of this holosystolic backward flow straight into the left axillary region. Question 7. For a patient undergoing mitral valve intervention for severe, symptomatic degenerative mitral regurgitation, what is the preferred surgical approach? Options: A. Mechanical valve replacement, B. Mitral valve repair, C. Complete suture obliteration, D. Isolated balloon valvulopathy. Answer B. Mitral valve repair. Repair is vastly preferred over replacement because it avoids long-term prosthetic risks. Furthermore, it preserves the native subvalvular apparatus, specifically the chordae tendineae and papillary muscles, which is absolutely crucial for optimizing postoperative left ventricular geometry and function. Question 8. 65-year-old male with wide systemic pulse pressure, 160 over 50 millimeters of mercury, bounding water hammer peripheral pulses, Corrigan's pulse, and high-pitched, blowing, decrescendo diastolic murmur at left sternal border. Options: A. Mitral regurgitation, B. Tricuspid regurgitation, C. Aortic regurgitation, D. Pulmonic stenosis. Answer C. Aortic regurgitation. Blood flows backward from the aorta into the left ventricle during diastole, which produces that decrescendo diastolic murmur. The exam Pearl explains the hemodynamics here. The massive stroke volume paired with rapid diastolic runoff creates a wide pulse pressure, which is exactly what you're feeling with that bounding water hammer pulse. Question 9. When counseling a 35-year-old patient regarding mechanical versus bioprosthetic or tissue valve replacement, what is the primary long-term operational trade-off? Options: A. Mechanical fail early/tissue lost forever. B. Mechanical offer durability but mandate warfarin/tissue avoid anticoagulation but degenerate in 10 to 15 years. C. Tissue mandate higher anticoagulation. D. Mechanical grow with host. Answer B. Mechanical valves offer permanent structural durability, but they are highly prothrombotic, meaning they require lifetime warfarin use. On the other hand, bioprosthetic tissue valves avoid that mechanical thrombogenicity and the need for heavy anticoagulation, but they suffer from structural degeneration over 10 to 15 years. Question 10. IV drug user with high fevers, new hollow systolic murmur at lower left sternal border intensifying during inspiration, Carvalho's sign, and septic pulmonary emboli. Which valve is most likely infected? Options: A. Mitral, B. Aortic, C. Tricuspid, D. Pulmonic. Answer C. The tricuspid valve. Right-sided infective endocarditis, often from Staphylococcus aureus, classically targets the tricuspid valve in IV drug users due to the direct introduction of skin flora into the veins. The exam Pearl here is Carvalho's sign, where the murmur intensifies during inspiration because of negative intrathoracic pressure pulling in more blood, inevitably leading to those septic pulmonary emboli. Question 11. During standard cardiopulmonary bypass, CPB, where are arterial and venous cannulas positioned for full systemic mechanical support? Options: A. Venous in femoral artery/arterial in SVC. B. Venous in right atrium or vena cava/arterial in ascending aorta. C. Both in left ventricle. D. Venous in pulmonary veins. Answer B. The venous cannula is placed in the right atrium or vena cavae to harvest deoxygenated systemic venous return before it enters the ventricles. After oxygenation, the arterial cannula is positioned in the ascending aorta to return that freshly oxygenated blood to the body.